do their best with all the recommendation, written action plan to address the symptoms, the treatment they're receiving, but they're still not well controlled. And then the provider on the other level, with all the guidelines that are being published, quality measures, all the effort that the accountable care organization are doing, and all the effort to standardize care, but patients still not well controlled. Why? Because of the barrier that exists between providers in the clinics and patients at home. There is no communication between them, and they see each other mostly during an asthma attack. And what we are trying to do is how can we remove this barrier and create ongoing communication so that the provider in his clinic can see what is going on in patient lives to act early instead of to wait for a patient to have an asthma attack. What we did, we contacted Michael Schacht, is a respected leader in the world in asthma. He developed a tool, asthma control test. If you have asthma, you go to see a primary care provider. This is a tool that we give you to assess your level of asthma control. Usually it gives you an average of level of asthma control over the past month. We asked Michael Schacht, say, can we change your tool to a weekly tool so that instead of waiting for a patient to come to see you, you want the patient to use it early and then to try to identify the needs. And Michael Schacht was happy. We even published a paper with him. What we did, we create what we call asthma tracker. We changed his questionnaire to a weekly questionnaire to assess the symptoms, to identify a score about the level of asthma control. And also we add this visual display. Now we're helping parents, or not only parents, also primary care providers, to see what is going on. And also like this case, when patients is dropping, they say, oh, we need to identify why, so they can act. And the goal is to leave the patient, to have the patient stay in the green zone. And we give them also recommendation, what they need to do when they're falling the red, yellow, and green zone. Now it's not just one point in time, but now a visual display, what they need to do. What Asthma Tracker is doing, this is data for real patients who have used the paper Asthma Tracker. Like this patient, asthma was not well controlled. The provider is saying that adjust therapy. The patient didn't achieve optimal control, then adjust again until achieve optimal control. That's what the goal for a provider to see, to do. And this is a case that was sad, where the patient achieved optimal control faster after hospitalization, but then the patient ran also out of control of medication, a patient with Medicaid. We didn't have the resources yet to send them. And what happened, this is a pattern that we see also before an asthma attack happened or an hospital admission or readmission. This patient dropped until the patient was readmitted back to the hospital. This hospitalization could have been prevented. And we test asthma tracker in 2010 patients. This is without engaging them when we developed the paper asthma tracker. But we say, oh, let's bring them back. Let's ask them about the perception of the tool. We did a focus group with 5 parents. Overall, they said the tool asthma tracker paper-based was useful and helped them manage their child asthma better. But they also talked to us about the limitation of the tool, that there was not a real-time reminder, because some of them we put the asthma tracker on the fridge, some on the table. They wanted something to remind them to do it regularly. And also when they do it, they have to calculate the score, plot on the graph, and then it takes time, and then look at the recommendation. They wanted to see real-time feedback, what they need to do instead of going through these exercises. And no quick access to a primary care provider. A mom was saying, like, if my child is in the red zone, I want my primary care provider to know it right away. I have to bring the graph, schedule an appointment, bring the graph so that my primary care provider can see that. And what was surprising, we designed a tool to help them, but when a child is in the red zone, parents were feeling guilty. Am I a bad parent? That was not our intent. How do we address that? And they came with the idea that we have to develop an electronic system, and they provide a wish list of the electronic system that they need to be linked to the primary care provider. They need to see if, like my child in the red zone, I need to have my primary care provider get my information right away. If I have a child, is a teenager using the tool, I need to get an alert when my child is not doing well. And we create a multidisciplinary team to define what the requirement for the electronic tools, taking into account what parents told us. We developed the first prototype for electronic asthma tracker, and then we brought parents back again to test the tool. We brought 10 parents and 4 teenagers, and they found the tool useful and easy to use, but they have also many problems that they identified that we're not thinking about. Many issues with the asthma tracker that we have to fix before we launch the electronic asthma tracker. These are some of the concerns and suggestions, like lack of motivation about sustained use. One parent was saying, like, if my child is using asthma tracker, I'm in the green zone, why I have to keep using asthma tracker? And also, they wanted real-time reminders, and some of them wanted their own time, like I want to do it at 6 p.m. I want a real-time reminder to give me, to allow me to do asthma tracker, and also easy access to the web. And also, we talk about what feedback, alerts, and concern about lack of primary care provider involvement. And the problem about low score also, especially red zone, came back again. The parents were worried about the child to be in the red zone. And also some of them, is it effective? If I use it, is it going to prevent my child to go to the ED or to the hospital? These are questions that we use all this feedback to write a PCORI proposal based on, because we engage parents during the development process. And this is how we address the problem. About sustained use, we add education. We have video telling them why they have to do it, and also incentive mechanism. We're going to give you some examples here. And we have a real-time email and text reminders and with a link so families can access the electronic asthma tracker. And we're providing also real-time recommendation for parents and alert to a parent if a child is using it. And we also address the low score. They want, well, that was amazing because they asked to have a free text field, so they can justify the reason a child is in the red zone. Like one mom was saying, my child, we went to visit grandma as a cat. My child is allergic to cat. I want to justify that. And this Joe is gonna, Dr. Johnson is gonna talk about how he's using this free text field now to get more information about families. They also asked to develop a mobile version. We developed a mobile version, and then we obtained a HRQ grant and a PCORI contract to be able to assess the effectiveness of the tool. This is how asthma tracker looks like. This is the web version, the home page. This is the first page with the 5 questions. It takes less than a minute for a family that is used to asthma tracker. And then when you go to the second page, we will give you the score, and then also get information about your current therapy, and also compliance with the therapy, as well as also some of the outcomes data we want to get. But this is an important field also that we identify that clinics are using a lot, the common field that families are using. And you're going to hear more about this. And we provide them also incentive. Like every time they use asthma tracker, they get 25 points. And then when they reach 100 point or percent, then they have a fireworks with a congratulation message telling them what they accomplished. Then we promise them also that they will get to the mail $10 Amazon gift card. And we compare also the use of asthma tracker to the best users, so we motivate them. We have also the clinic view, where the clinic, they can look at all patients using asthma tracker, or they can focus only on those who need help. They may not need to access the asthma tracker because a patient in the red zone, the clinic will receive also an alert to tell them that where the patient is. And they can even click and see the detail on the graph about the patient to see what the patient is doing, how the patient is doing. And this is the mobile version of the tool with there's a different layout. And what we have accomplished with asthma tracker is the barrier that we showed you previously. We removed the barrier. Now asthma tracker become a bridge between families at home and provider. We're changing the paradigm of care now. When a child is not doing what the clinic calls, instead of waiting for the family to schedule an appointment, the clinic calls and try to address the problem. Families, they love it. And there is an ongoing communication between clinics and families at home. We obtained a PCORI contract. The title was Redesigning Ambulatory Asthma Care, because it's a different ambulatory care model, which we use Asthma Tracker to support this model. And the goal was to assess the effectiveness of the tool at the level of the child, parent, and clinic, and then to identify what parent characteristics that affect what child outcomes. And then lastly, we wanted to identify what are those factors, barriers, and facilitators that can help us when we want to disseminate electronic asthma tracker outside, what we need to address at the parent level, at the organization level to be able to sustain that. I'm going to have now Jordan talk about perspective, how she participated in this project and how it shaped our project. Then I will come back and show you some of the data. Yeah, I don't know.
All right, is it working now? A little better? Let's see if I can get it up here. Okay, sorry about that. I'll try to talk really loud. So I'm Jordan, and this is a picture of me and my son Graham, who was mentioned. He's 3.5 years old now. I like this picture because we were in San Diego and we were walking out on a pier and we just happened upon that pelican you see in the background, and we got pretty excited about it. So he had RSV when he was 4 months old, and then again when he was 6 months old. And it's kind of a chicken or the egg thing, right? So the doctors don't know if he had asthma before then, and maybe his breathing problems made him more susceptible to getting RSV, or if it was the other way around and he had RSV that maybe triggered the asthma. No one really knows, but it's a pretty common experience. He was also on oxygen for his whole first year, so that was kind of a tough thing for us. Getting up every night. Someone actually at one point said, "Oh, you need to get more sleep." Well, it's kind of the issue that that Victor was talking about. I was in that same situation, except that it wasn't me who was ill, it was my son. So good luck getting more sleep at night. As part of the study, I'm going to move over here a little bit. I was asked to participate in this study by my pediatrician, who has been great throughout the experience. And I'm in the study with 4 other moms. So all 5 of us are moms who have kids with asthma, and they're of varying ages. So Graham is the youngest in the study, and we started when he was about a year old. And now, and there are parents who are in a range. So there are parents who have, kids of all ages, and they have different levels of asthma. Some of them are teenagers. So it's been really interesting for me to get the perspective from those moms. So living with asthma, as I mentioned, was relatively new to me, and I have learned a lot through this experience. So parent stakeholders, researchers, providers, and everyone else who was involved in the study gathered at the beginning to have a kickoff retreat, and they wanted to talk about their needs and prioritize. I'm just going to sit down. And this really gave us a chance to prioritize what we were going to talk about during the whole study and how we were going to define the criteria. The really neat and unique thing about the study is that the parents were on the same level as everyone else. So at the beginning, the expectation was set that, researchers' opinion isn't more valuable than the physician's or than the patient. Everyone's opinion was important. We decided to hold quarterly stakeholder meetings with the entire group. So we held those every quarter, and then we divided into subgroups that we held monthly. One of those was a social networking group, and they started a Facebook page. There's also a newsletter committee that I was a part of, and then there was a focus group committee who held focus groups with one of the physicians and talked to parents about what was working with the asthma tracker and what they felt like could be improved. And then we met monthly with in the clinic support committee. So there were clinic managers from each of the clinics that would meet on a monthly call and talk about what was working in their clinics maybe what wasn't working. Clinics whose enrollment was up, we would talk about what they were doing right or how the process could be a little bit more efficient. And again, like I mentioned, the really unique and neat thing about the study is that it's been an equal partnership with no hierarchy. So I thought it would be helpful to talk a little bit about how parent involvement actually helped shape the research, because that, again, is what is so unique. First of all, we helped identify what we were going to study. So if we were really interested in how the e-asthma tracker impacted and whether or not it really made a difference, as Dr. Nkoy was saying. And then we also wanted to assess factors associated with sustained use. So does it make a difference if you're using it continually? I kind of like to think about it when you're in the green zone. Parents don't realize how important it is to keep using the tracker, but I think about it as if someone were using an antidepressant and they go into their doctor a month later and they said, oh, I felt so great, I just stopped taking it. So it's important to keep using it, otherwise you won't identify those changes. We also helped identify meaningful outcome measures. So some of these are the questions that you saw on the slides that Dr. Nkoy talked about and that Dr. Johnson will talk about. So are there nighttime symptoms? Does it affect your quality of life as a parent? Maybe you're getting up every night like I was to deal with Graham's asthma and put his little oxygen back in his nose. And also assessment of our daily work interruptions. So initially it just asked whether or not we had a full day off of work, but sometimes it's just taking some time out of work to deal with their asthma, or maybe they missed a partial day of school and not a full day of school, and we weren't assessing that before. And it's also obviously the most important to try and avoid a full-blown asthma attack and end up in the emergency room. And I'll give you an example in a minute of how that affected me. And then we also asked to modify the study design. So we requested that instead of just some patients receiving the e-asthma tracker intervention, that all patients get the e-asthma tracker, because we thought it was so valuable and we didn't want any other parents to miss out on this opportunity. And we changed from a cluster randomization to baseline across design. So initially the e-asthma tracker was only going to be used in some of the clinics, and what they started doing was they started with half of the clinics and then started introducing it slowly to the other clinics, and then started using other ways of a control. So Dr. Nkoy talked about the version with the fireworks, and then there is a version that doesn't have that. And then we also asked to modify the participant age. Again, this is something that we felt was so important, because initially it was for children ages 2 to 11. But if you think about it, teenagers are often the ones who need that asthma control and the check-in the most. So one of the parents in the study has mentioned that she's really glad that her teenager, she knows if she fills it out. So let's say she didn't fill out the tracker, then she'll get an alert that says, hey, Abby didn't fill out the tracker this week, or she's in the red zone. And she's really glad to have that. So we wanted to include those participants. We also helped with clinic enrollment. So some of the parents went to clinics and actually visited with the physicians and the clinic managers and sort of gave them the parent perspective and explained to them why it's important, and encouraged them to participate. So they were really seeing why it was important to us and not just seeing it from a clinical perspective. And then they also helped in participant recruitment and retention. So for instance, in our clinic manager calls every month, we identified that it would be helpful to reach out to some of those patients who had asthma or whose children had been diagnosed with asthma, but maybe they hadn't come into the clinic for a visit and they might be interested in participating in the study. So we wrote a letter that they could send out to those patients. And then, as I mentioned, the social networking group designed a Facebook page, and members parents can go there and check in with us and ask us questions and feel like there's a community that is out there to help them. And I'll show you an example. We developed a newsletter. Initially, we were just doing stakeholder newsletters, which was really helpful, but then we decided to do a parent newsletter as well. And there are some YouTube videos out there. Dr. Johnson and some of the patients and some of the parents involved in the study did some testimonial videos that help you understand really why the asthma tracker is important and give you that personal perspective. And then finally, we helped in dissemination of the study. Some of the parents actually worked with Dr. Nkoy to submit and present abstracts at conferences. So it was important to us to become active in the study and participate and be engaged patients, not just participants. So here's an example of one of the parent newsletters. It contains articles that might be helpful, like how to care for your spacer, things that you might know, but sometimes you may not get from the clinical experience. I actually learned a lot through writing the newsletter and through working with the other parents who were on the newsletter. Sometimes there were little tips that I had never gotten from my physician, like, oh, if you drop your inhaler, you need to reprime it again before you use it. on your son, and no one had ever told me that. And then I asked my doctor, and he said, oh yeah, that's true, but you just don't think about it in that 7 minutes that you're in the office. And then we felt like it was important to really bring the clinical perspective and help encourage them and realize why physicians found it useful. This doctor said that families really appreciate the interaction and the feedback, especially when patients are in the red or yellow zones. So here's an example of what happened to me and how the asthma tracker was really useful to me. In addition to helping me track triggers, I've been able over time to see when he's in the green, but then when he starts to dip. Now, after using it for a couple of years, I know when he's going to dip before he dips. For instance, if the barometric pressure drops like it has in the last couple of days, I expect it to go, his breathing to sort of have a blip there for a few days, and I know that's going to happen. So last year, my son had been controlled for 2 years, and last year we tried to get his asthma medication down a little bit. He was on 2 puffs in the morning and 2 puffs at night, and they want to get it down to a lower level and see if he can handle that. So we did that, and it was going really well, but then his breathing started to get worse, and that week when I filled out the asthma tracker, I went in and made a few comments about what had been going on during the week and submitted it. And literally within a few hours, his pediatrician's office called me and said, what's going on? We need to talk about whether or not he needs to go on some oral prednisone. That was really amazing for me, because normally it would be something where I would need to take time out of my busy workday to call and try to get a hold of him and maybe leave a message and go through the front desk, and maybe we'd play phone tag with the nurse for a couple days and she would ask the doctor, and you get the point. It would take a long time. But instead they called me and they said, the doctor has looked at the record and here's what we think you should do. And they started him on some oral prednisone right away and potentially avoided a serious asthma attack. So in summary, here are some stakeholder stories and what we found was really useful as parents participating in the study. First of all, like I said, it's two-sided. So treatment is more personal. It incorporated patients' views and not just clinicians. It was really important for us to be able to have a voice in the study and help them see a certain perspective, and then they were able to help us. I also really appreciated the friendship and support from other moms. It was interesting for me to listen to that previous presentation and think about how people don't think of asthma as an ongoing chronic illness, and so there aren't really a lot of resources. You don't get anything outside the clinical experience. So they diagnose your child and they send you home with a piece of paper and you're trying to figure out all these medications and exactly, well, is his breathing bad enough to change it? I don't know what to do. I don't know if I should call. But it was so neat for me to get to know the other moms and learn about their experiences. I really learned a lot. There's not any sort of support group for moms with asthma, and that was a huge benefit for me as part of this experience. We also we appreciated the proactive calls from the clinics, like the one that I mentioned. And then the clinic visits proved to be a useful way to learn about how the tracker was actually being used. So there were parents in the clinic who, or when they went to visit the clinic, they found out, oh, this patient ended up in the red zone because they weren't filling out the tracker in the green, and the physician never saw that dip like they did with my son. And so now Dr. Johnson is going to talk to you a little bit about the primary care provider experience.
I hope I can get this thing to work. I'm Joseph Johnson. I'm a pediatrician from Provo, Utah, and I have been involved with this from the beginning as well. And I'm a private pediatrician, so I have some interest in research, but it's not the primary thing that I do. But I really like asthma. It's one of my main interests, and so that's why I wanted to get involved with this project. I actually started becoming involved as a member of the Intermountain Asthma Group, which actually initially, this is about 9 years ago, where I was asked to be a part of a big group of clinicians from Primary Children's as well as some community hospitals as well, and trying to standardize what we do with inpatient asthma. They had kind of piloted a very similar project at Primary Children's, and then they wanted to try to disseminate it out to the other hospitals throughout the community. And so I was the representative from Utah Valley Hospital, which is in Provo. And that was primarily an inpatient focus. So we were looking at what we were doing when the patients were admitted to the hospital and how to make sure that we were doing it the same way and doing it with good quality. But that was not the main focus of what I do. I do inpatient work, but my main focus is outpatient work. And so as part of this study, they had this research arm to it. And Dr. Nkoy introduced this probably 3 years ago, I would say, to this group and talked about this e-asthma tracker that they were working on. And towards the end of, so it was about 2013, they started talking about how they wanted to disseminate it out again and get a study going with community involvement with groups and pediatricians. And so they asked me if I would be involved, and I said that was great because I was really excited about it. What I had been doing prior, let's see, I'm getting ahead of myself. So my role in the PCORI project, I'm a physician stakeholder, and I also was involved with recruitment. I was able to recruit a parent from my practice, Liz Malmgren, who has a couple of children with asthma who are part of the study as well. And then also Andrea Jensen, who's from the Utah County Health Department, was interested as well, and so I asked her to be involved. She was also on the Intermountain Asthma Work Group, and so she very readily accepted because she also has children with asthma as well. And then I also was involved with physician and office recruitment in Utah County, and I did some site visits, as Jordan was talking about, the parents did as well, so that I could explain what we were doing in our clinic and why I thought it was important to try to help other clinics to be involved as well. So one of the things that I've learned the most from this study has to do with this video. About a year after we'd been doing this, there was a convention last year in Washington, D.C., where a bunch of different groups who had PCORI grants related to asthma from across the country came together and presented our studies that we were doing and kind of brainstormed together, try to help each other figure out how to make them better. And on the second day of the conference, they had a person who came, is Dr. Michael Rich from New York. I can't remember which hospital it was, but from New York, who came and presented this video. And what they had done in this video is they had given their patients in their study, the study had something to do with living with asthma, I think is what it was called, or something to that effect. And basically what they did is they gave them a video camera and they said, we want you to take videos of what it's like to live with asthma as a patient. And so he spent, this video was about 5 minutes long. We just have the most important and scariest part of the video here that we wanted to show to you here. And this really drove home to me why we're doing this. And we've talked about how, asthma is not just a disease the patients have, it's a disease their families have, and it's scary not knowing what to do with it. And after watching this video, I hope that you'll appreciate this as well. Well, I don't think I can do this with this pointer. Do you want to? This was the most poignant part of the whole conference for me. So if you just click on the arrow. So she's driving to the hospital with an asthma attack. She's a passenger, someone else is there. She has a video of just sitting in her lap, looking up at herself as they're driving her to the hospital. She's about 13. So all of those who were at this conference were white-knuckled watching. This video is about 3 times as long as we were watching her being driven to the hospital, waiting for her to get to the point where there was some albuterol going and we could finally relax and say, at least now something's being done. I had a similar experience myself. I took a group of scouts down to Goblin Valley. If anybody's familiar with Goblin Valley, it's in the center of Utah. And it's about 100 miles from anything at all. And so we took a group of scouts down and we went on a Saturday to hike Little Wild Horse. It was just a slot canyon right outside of Goblin Valley. And one of the scouts in our group, unbeknownst to me, had asthma. So we went there, we went ahead, and he didn't really want to be on the hike. He wasn't one who did a lot of adventurous stuff. And so he stayed back with a couple of the other scouts and other leaders. I took a group up. We were gone for about 5 hours and came back down to a child looking like that in Goblin Valley, 100 miles from anything. And I had to drive him back. I had gotten an hour of sleep because I was with scouts. I had gotten an hour's sleep, and I had to drive back for 3 hours with a child in the back of my car. Ian, are you all right? Are you still breathing, Ian? About every 2 minutes on the way home, and it was terrifying. I knew what to do, but I didn't have the things that I needed to do, and I can only imagine the same thing here, especially if you're a parent and you don't really understand what's going on with your child. So that really drove home to me the importance of what we're doing and trying to help patients to be educated and be a part of their care. So prior to the asthma tracker, what I did in my office is we used the asthma control test, which again is those 5 questions. How well is your asthma controlled on a scale of 1 to 5? And if the score is 19 or above, that's the green zone. If it's less than that, they're not well controlled. We also would have patients come in for regular visits, usually about every 3 months, sometimes longer depending on if they made their visits or not. And it's very difficult when you come to the office to try to remember what happened about 3 or 4 months ago. And so the visits were not always very helpful because we would say, well, how's your asthma? Well, are you having nighttime symptoms? Are you having daytime symptoms? How often do you use your inhaler? They're like, well, I think I had something 3 months ago. I can't remember. And it just wasn't very effective. And we would give an asthma action plan based on very incomplete information that we received from the patients trying to hopefully, and their parents trying to hopefully help them to control their asthma well. So when I found out about the asthma tracker, I was very excited because it was something that could give us real-time, weekly, daily information from our patients in order to actually better manage their asthma symptoms. So I introduced it in my clinic to patients who had persistent asthma. We actually offered to be a part of the study to about 30 parents and their children, and 25 of them accepted. And I talked this thing up like crazy for about 6 months because I knew it was coming out. It was released January 2014. And for the 6 months prior, every time they'd come in their visits, we've got this great thing. I'm really excited for you to be a part of it. And they were excited by the time we started, and it was very easy to get them enrolled. And like I said, most of the ones that we offered it to enrolled in it. They did like the incentive, which was the Amazon gift card that Dr. Nkoy talked about. But I found it interesting. The study lasted a year, and then the parents were given the option to continue using the asthma tracker outside of the study without an incentive or to just stop. And about 40 to 50% of my parents still use the asthma tracker, even though they're not part of the study, and they get no incentive for it other than the fact that they can help control their child's asthma. So the positives that I like about it, the patients understand their symptoms. They actually understand their asthma medications. I saw somebody chuckling up here when they were talking about all these different medicines and which one am I supposed to use. Inhalers all look exactly the same. So you say, okay, use the blue one for this, use the orange one for this, but they don't really understand the difference between the two of them. Having this and having to answer a question, when are you using your controller medication and how often are you using controller medication, it helps us to drive home, be able to teach this medicine won't help you when you're having an attack, but you need to take it every day, even if you feel good, because this is why you feel good, is because you're taking this medication. And the parents liked it because it reminded them, you know what, I only took the Flovent three times this week, and look how bad a week we had. I recognize that I need to do a better job at doing that. And the comments were very helpful. We'll show you some examples of those, and I'll tell you a couple of other ones that I've had that have been very helpful as well. And again, the follow-up visits were much more useful because now we could look at it. What we do in my clinic is we print out the last 3 months on the asthma tracker when they come in for their visit, and I can say, okay, let's talk about each of these things. If there's comments, we talk about the comments. If we see them dip, we talk about why the dip happened. And hopefully they put a comment when the dip happened so that we can actually help to remind them this is, oh yeah, we went to grandma's house and they have a cat or something else like that. There are surveys that are part of this where the patients every 3 months are asked to fill out how they're doing with the asthma tracker, and that again helps to remind them to do this. And then the other thing that was nice about the productive care problems, so within 2 weeks of starting this study, we had 2 patients that were in the red zone that we were able to call on the phone and get going on prednisone so that they didn't end up in the emergency room and they didn't even have to come to the clinic. They were able to get going, and it was great. And that's happened frequently throughout the time that we've been doing it. And even now, just a couple weeks ago, I had another patient who actually is not in the study anymore but was in the red zone, and we were able to get him started on medicine again as well. And I found that the parents are much more aware of what's going on, so sometimes even before we as a clinic have a chance to call them, they've already called in and got a hold of us. My practice is small, so it's not that hard to get a hold of us, but they've been taught that when my child's in the red zone and when they're having these problems, I need to call in because we've been calling them, so now there's much more of a two-way communication that's happening. So this is what it would look like in the clinic setting. We have 25 patients that were originally enrolled, and like I said, about 10 to 15 that are still doing it even at this point. So every week, and those boxes represent every single week, they fill it out. If they don't fill it out, it's this negative sign within the black box, and then if they fill it out, they have a score there, and you can see the color coding with it. So the way it worked in my clinic is every morning my care coordinator, who's my office manager, would get on the asthma tracker, Takes 5 minutes. She'd run through everybody, see if there's anybody in the red zone or if they've been in the yellow zone for a couple of weeks, and then start calling. We have a group in our study that has 100 patients that are on the asthma tracker. It takes them a little bit longer, about 30 minutes, to do the same thing. But they have somebody, again, a care coordinator who's specifically devoted to doing this. So it's not that onerous. And there are many days when, at least in my clinic, because we have a small number on it, where we didn't have to make any calls because everybody was doing fine. Then if we made a call, we decided what needed to be done. She gathered information over the phone, and then she talks to me between patients. We decide if anything needs to come in, if we need to start prednisone, if we need to do something else with them. So it doesn't take very long to do it. Other things that are really nice about the asthma trackers, there are educational resources and games for families, for kids, and for their parents. So if they want to learn more information, it just helps to reinforce what we're talking about in the clinic. So this would be what it would look like. So this is a patient's score. And you can see, I guess there's a pointer on here. Which one's the pointer? Is it this one? Sorry, I don't want to laser anybody here. So you can see these little dots and these little stars. And these all represent different things in the asthma tracker. So if you actually if you're on the tracker, which this is, we're not on the tracker here, but this is an example. If you were to put your cursor over this, it would tell you, I think this is a comment. And so you can find out what the comment says. Some of these represent visits to the emergency room, admissions to the hospital, different things like that. So every time you put your cursor over one of these, it tells you what it is, and then if it's a comment, it tells you what the comment is. I'll show you a couple of comments. And you can do this for an extended period of time. You can do it for 3 months. You can do it for a month. There's different ways that you can change it. So this is one of the comments. So this child has, so this would be probably, I think it's this comment right here. Nasty cold that's going on. We're using albuterol, hopefully, to help it to get better. Another comment is this one, which is my favorite comment and very helpful in this idea of, as we learned in the last lecture, sometimes patients can't afford the medications that we prescribe for them, and they don't want to tell us that. But they will if we're not right in front of them sometimes. So this patient says, we ran out of our singular prescription and didn't tell me. In this case, it was because this was a teenager who's being taught to self-medicate and didn't bother to tell her mom that she ran out of her medication. But there were others that I've seen where they lost insurance and they couldn't afford the medication anymore and they didn't want to tell us, but they would put it on the comment section. Also, I had a patient who was using doTERRA oils in order to treat their asthma, and we had a long discussion about how that's not a good idea because it's not going to help you to get better. So there are other comments that are very helpful, and again, people are usually much more willing to do things online where you're not sitting right there than they are right in front of your face. And this is the second page, which is after they've done the first 5 questions, the asthma control test. This is, again, what medication are you on for your controller? How often are you taking it? I found a lot of parents who really appreciated the reminder that these medications for controller need to be taken every single day to be effective. And you could show them, see how you only took it twice this week and you haven't taken it very well this past month. Look how much worse your scores are now. And it just reinforces what we're trying to do with them. And then the comment section at the bottom, which is, again, my favorite part of the entire thing because you get a lot of good information from that. So what I've learned from my participation in the study is that patients and parents, they want to understand their disease better. They want it to be controlled. They don't want it to run their life. And they have lots of ideas. It was very interesting to me when we had the initial meeting where we had the parent stakeholders, the physician stakeholders, and the researchers there. The parents had many, many ideas that we would have never thought of because we don't live with these diseases every day. We treat them and we see them, but we don't live with them every single day. And so, for instance, the thing that probably was the biggest thing was the need for social media and a group effort with this. Being able to talk to other parents was probably as important to them as anything else that we did. And we would have never thought of that on our own if it was just the physicians and the researchers. And if we can partner with these things, we get great satisfaction. It's been amazing to me how, again, I still have about 40% of my parents that are not even on the study who still use it and they love it. And they're going to continue to use it. Some of them have had children admitted for asthma. Since I've been on the study, none of these patients have been admitted to the hospital for asthma. And about 5 or 6 of them were admitted for asthma at some point in their life prior to that point. And a lot of my parents that like the asthma tracker don't even have kids that were admitted for asthma. They were admitted for something else. But they use the asthma tracker because they feel like it gives them control where they don't have to worry as much about their child anymore, and it makes a huge difference for them. And I'll turn the time back over to Flo.
Is it on? Is it on? Okay, I will give you a quick, to finish with some data. We're still analyzing we have like 2 months, we're pulling the data for the PCORI, but the data I'm going to show you is when we test the electronic asthma tracker with patients admitted to primary children. But currently we have 12 clinics using asthma tracker. We have about 320 patients using asthma tracker right now. This is what you see when you're using asthma tracker. Patients who are using asthma tracker have longer time to first admission than patients who are not using asthma tracker. And also, we look at patients who use asthma tracker compared to non-users. This is what you're seeing here. And those who use asthma tracker, they have a reduction in asthma readmission. This is prior and this is after. And the control, there is no change at all. And what is important is the frequent users, because they use it at least 60% of the time. It means the provider have more opportunities, even themselves, to act early because they identify needs more. When you are a frequent user, the impact is even bigger than when you are infrequent users. Something that interested me when I was looking at this, because Medicaid, it has been shown like patients with Medicaid, they have a high asthma admissions. As you can see also, asthma admission in patients with Medicaid. Those who are using asthma tracker and those not using asthma tracker. And among those users, these are frequent and infrequent users. Frequent users, look at the impact on a patient with Medicaid. And these are infrequent users. And this is now the PCORI because we don't have data in outcomes. But what I wanted to show you here, the engagement, because the limitation of self-management tool is high attrition. But these are the frequent users, not the old patient, but frequent users. Those are frequent users. 10 months in the study, more than 75% are still using the asthma tracker frequently. Because all the efforts that parents, the primary care provider, you engage everyone, you see this kind of engagement also on users. This is something we got from my parents who are using asthma tracker. What I like is this sentence here. Because thanks for allowing me to be part of the study. I feel guilty when you keep sending me Amazon cards. Because I feel like the real benefit is knowing we have got asthma under control. I want to conclude the traditional research usually include scientists, and as we used to do it before, but right now we're including also stakeholders in all aspects, the design, implementation, dissemination of result. And these are experts. They have expertise that we learn from, and this is something that should be included. And it's something we learn, and some of my colleagues are saying, I cannot do this study as I used to do it anymore. I need to include stakeholders from the beginning. And the benefit of including stakeholders, you have greater engagement. We show you with how patients are still engaged, and also meaningful study participant involvement. And the research is more useful and trustworthy, and can lead to great uptake of results. I want to thank all of our team, and thank you. No, I'm okay. For the study, we recruit clinics. We have 12 clinics right now using it, but after the study, because we're working on a model how we sustain it after the study, that's when we're going to try to make it available for anybody who want to use it. But right now, it's just part of the study. But we allow clinic when they finish for families to continue. Clinic will like to use it as a part of quality improvement, like Dr. Johnson said. But right now, we have just 12 clinics we're using.
So the study ends in July, so.
Yes.
And Dr. Griffin, can you repeat the question so everyone can
Okay,
The next one. Yeah.
okay.
I'm not a pediatric researcher, but thanks for a great presentation or a pediatrician. But what's the level of current confidence in the relationship between air quality and pediatric asthma? And is there an opportunity for families that are involved, if the, you know, the confidence in that relationship is high, is there a way to use the qualitative stories and information from parents as an advocacy tool?
Yeah, the question is about the relationship between air quality and asthma. It's something that we are looking at. We even published a paper about how we can predict asthma control deterioration a week before it happened, using patient factors, including also what is going on around them in the air. But right now, families are discovering themselves because they're entering their triggers and they can associate when what deep and up based on the triggers. But what we're planning to do later is, because we're working with computer scientists to try to develop a predictive model where we're going to link, but we have to test it first before we bring it to asthma tracker. But it's going to be part of the asthma tracker. The goal is you look at previous data and see how patients are reacting. The asthma is changing, then you can predict if the same condition happen. You can send an alert to the patient like, okay, this condition, usually when you have this condition, this is what happened to you. This condition is happening now. Make sure that maybe you increase your dose or contact your primary care provider so you do a proactive management.
Did you keep track of the reasons why people chose not to stay on the asthma tracker? Because you lost 60%.
Right. So most of the ones who, I found that most of the ones who still did it had some sort of a pretty significant experience with their child, and it didn't even have to do with asthma. So for instance, I have one family that does it, and their child had meningitis, bacterial meningitis, when he was 4 months old and almost died. And they use it very faithfully, and it doesn't even have to do with asthma. So the ones that have had a serious life event are more likely to be using it. That was
What
probably...
about those that stopped?
They-
What were their reasons?
Most of them were well controlled on their controller medication.
So they didn't feel a need.
Right. Because they had 25s for 6 months or 10 months or 12 months. And their children were also a little bit older, and so they may have had problems when they were younger, but they were kind of growing out of asthma. But it was interesting, again, that I found that a lot of the families that stayed on, even if they had younger children, they had had a very significant life experience, and it didn't necessarily have to even be related to asthma. And but they felt that it gave them control because they could have something else, and they were closer aligned with me than they would have been otherwise. So they stayed on it.
I think this is a good question also, is a part of speaking number 3, because we want to understand that better. But if you look at some of the comments of patients who have stopped, it's mostly, these are mild, maybe asthma, then persistent, those who are moderate or severe persistent asthma. Because those who have persistent asthma, moderate to severe persistent asthma, are more likely to use it than those who are mild, stay mostly in the green zone. These are the ones that I think stopping. And I think it's mostly what Dr. Johnson said about the needs. If the need is bigger, they have more problems, they stay using it. But overall, this is the data that we're capturing. We have a survey tool. We're going to analyze and try to understand, because we want to address it early to identify those who need more. Maybe we need to change the criteria. Maybe we need to focus only those severe asthma when we implement asthma tracker.
Yeah, so anytime, you're using technology, you have
Yes.
to find out the
Yes.
population that it's going to be most applicable to.
Yes.
And it sounds like you've got kind of a beginning feel for that.
Yeah.
I actually have a family that moved out of the state who still use it.
Yeah, right.
And they just really like it, and they just really find that it's helpful.
Right.
So
right.
Did you use a secure network for transmitting that patient information to your clinics? And if you did, was that a challenge? And how did you work around that kind of compliance that we all have to face with patient-level data?
Yeah, it's something, it was a pain when we were going through that. I remember. Yeah, but likely we use computer, the name of the, honey, the high-performing computer department. I think they have a secure HIPAA compliant network. This is where the data is being stored, and we went through all the security, everything. It was like almost 6 months just before we launched it. It was a pain.
If that's okay, last question? Thank you.
Okay.
My question's for Jordan.
Okay.
Jordan, thank you so much for being
Thank
here.
you.
It's so powerful to hear from the patient and parent of the patient. And you alluded to the fact that the social network you had with other parents was really important to you. But wondering if you can speak specifically to how that changed your level of engagement with your child's physician, or how did that change the practice of how you managed his
For one thing, I always print out the asthma tracker, so I'm able to print a printed copy and bring it in. So my pediatrician sees it, but my pulmonologist doesn't always look at it, so I bring it in and show him a printed copy, and then we're able to talk about, I am able to come in armed with knowledge so that when he asks me, how have things been going, I wouldn't be able to remember if it was just me, right? But I have that printout, and so I'm able to say, this is when he was a little bit sick, or this is when the inversion was really bad and that's why he dipped, but I think that he went back up and it's fine. And it's just made me feel a lot more committed, and it helps me to stay engaged as a parent. And like I said, talking to the other moms has been huge for me. Hearing about their experiences, and especially Andrea, who's in the back, hearing about what I can expect when he's in 3 pre-K, but once he gets in school, what to expect from maybe not having enough school nurses, or the fact that he can have his inhaler at school no matter what. Being armed with that knowledge automatically makes me more engaged and makes me able to help other parents who are dealing with the same issues.
All right, just another round of applause for a great presentation. Thank you.